All right. There we go. So Dr. Etzioni is a member here at Fred Hutch in the Population Sciences Division and also at the University of Washington. And she's really done a remarkable amount of work focusing on screening for prostate cancer, understanding how PSA works. But in this case, she's going to really focus on understanding health disparities, which, as you'll see, has very important implications across races and understanding how prostate cancer develops. So, Ruth? Yeah.
Thank you, Pete, and it's great to see everyone. As those of you that have been here before know that most times when I speak about prostate cancer screening, and we'd be very happy to answer any questions that you might have at the end of the session. I'm a biostatistician by profession, and the work in my group centers around trying to get the numbers right when it comes to prostate cancer screening and treatment, because there's so much confusing information in the literature. And if those of you that were here last year will recall that I actually spoke about prostate cancer screening and the two large trials of screening that seem to be giving different answers, but showing that if you looked at them in a certain way, they actually both were consistent in showing that screening was beneficial. And I want to thank Pete for giving me the opportunity to talk about this particular problem, because I'm going to come back to the three questions. I want to just show you the first point that I want to make, which is that, of course, prostate cancer is not, by any stretch of the imagination, a one-size-fits-all situation. And here I'm showing incidence rates between 1999 and 2014 in different racial ethnic groups. And the overall is the black curve, and African Americans are in red. And the Asians and Pacific Islanders are in blue. So you can see that there's a wide variation across populations. And in fact, the African American excess is one of the most dramatic disparities in cancer. And so really, we have a very non-representative audience because, in a way, of course, there's a lot more cancer in the African American population. And this was brought home to me a couple of years ago when I was invited to a conference put on by a national advocacy group for African Americans in Washington, D.C. at the Capitol. And I sat in a room, and everyone in that room was African American, and everyone had had prostate cancer. And here are the mortality rates. So that was the numbers of cases, and this is the mortality. And in fact, without screening, 1 in 20 African American men will die of prostate cancer. And we can learn a lot from these disparities, not just about cancer in the high-risk population, but about what drives risk and how we should be responding to this kind of disparity. Here's an interesting graph from the Institute for Health Metrics and Evaluation. So on the left-hand side, this shows prostate cancer mortality rates. And so you can, and then on the right-hand side shows the percentage of a county's population identifying as both black or African American and non-Hispanic. And so you can see that the high African American counties are exactly those ones with a high prostate cancer mortality. And so I'm going to just go back to the three questions. And so the first thing I want to do is I want to ask about the numbers, right? So the numbers that we're seeing, do they give us an accurate picture of the disparities? And is that really what we need to know? In fact, I'm going to make the point that what we need to know is what are the underlying differences in disease, because that's what's going to tell us how to intervene and what to be doing differently for the high-risk groups. And at the end, I'm going to be using this as a showcase, almost really to transition to our next speaker, because this notion of heterogeneity in risk doesn't apply only to racial and ethnic groups. We can identify high-risk groups, and then once we identify high-risk groups according to different criteria, what should we be doing specifically for them? So first I'm going to zero in on this African-American disparity, and here I'm showing a longer time period. This parallels what Pete showed, the up and the down of prostate cancer mortality, but here I'm showing it by the African-American versus the general population and this tremendous decline, and it looks like these curves are almost coming together, suggesting that maybe the disparity is narrowing. However, when you take the one group divided by the other group, so the ratio, the relative difference, it stayed pretty constant. It's not really converging. And the same issue comes with survival. So this curve shows by year of diagnosis, what's the 10-year disease-specific survival for African American and all races. And screening began in the late 1980s, and you can see these curves coming together nicely. And in fact, this was the subject of a paper by a very prominent investigator in this field, Dr. Powell, suggesting that, look how much better things are getting. Screening must be really good for narrowing the disparity. Now, in the interest of really helping you to see why it's so important to be thinking deeply about the numbers, I'm going to take a look at this optimistic picture and show you that, in fact, it's not all real. Because, and this is a paper that we just recently published in Cancer, because as you can see, I want to go back to the curve, you can see that the survival in both groups is getting better, right? This is the 10-year survival. It goes up, and they come together. So when you work in screening, you learn that screening improves survival even without any benefit, because when you screen a population, you detect them earlier. You might not move the time that they die, but you change their survival by virtue of detecting them earlier. And that's an artifact, because that is going to happen even if there's no benefit of screening. Screening is only beneficial if it moves the final endpoint. But when you look at survival, it looks like you're moving the entire thing simply because you're detecting early. So this was a paper that actually tried to quantify that in that convergence, and this is what we found. By age group, this is the percent of the narrowing that's accounted for by the artifacts of screening that's not actually real. And it's quite high, particularly among older men, that the narrowing between the race groups is actually not all real. And so even though it looks like we're doing better in terms of getting more parity, we might not be. And so the first question is, do the observed differences paint an accurate picture? So not really. And in fact, what we really need to know is the underlying differences. And when I talk about underlying differences, you have to imagine what we're not seeing when we see the observed data. Because what happens at a level that we can't see is that when the cancer starts, and then it progresses, and you don't know that you have it, and it's latent. And it might be a low-grade cancer, it might be a high-grade cancer. It will be screen detectable, but ultimately it's diagnosed, and this whole time you don't know it. But there's transitions between important clinical states that are happening. And a lot of our work is trying to understand what's happening beneath the surface here, and these arrows show rates of transitioning, how fast these events are happening, and these are the objectives of our statistical model and estimating from available data. So it might seem like a complicated picture, but really it's all about what's happening below the surface. How fast is cancer starting in different risk groups? How fast is it progressing in different risk groups that we can't see, but we can actually learn from available observed data going beneath the surface. And this is what we do a lot of work on. And why is this important? It's important because when we want to know how to screen a population, this is what we need to know. We need to know how long is the cancer being silent, because that's our opportunity for screen detection. If the cancer is only silent for a short time, then we have to screen very frequently to be able to pick it up. If the cancer is silent and non-progressive for a long time, we can screen less frequently. And biological evidence suggests that both the risk of onset and risk of progression are higher for African American men. And we have been looking at whether the epidemiologic data confirm this. And why is this so critical? Because none of the national guidelines for prostate cancer screening tell African American men what to do. They're all for the average risk population, and they kind of hand wave about what to do for African American men and high-risk group, men with a family history, because there are no big studies that really focus on these groups. And so we have to do this kind of working with the data to learn about them. Now, this slide is about 15 years of work, because when we fit that model of those underlying risks to the observed data, I'm showing you by stage, very impressive in black, the population, the reduction in distance stage down here for all races and African-American men, and the gold is our model fit. And so the question was, if we can fit this model to observed data, what does it tell us about the underlying risks? And here are the underlying risks. First of all, that black men have about a 50% higher risk of disease onset, and they have a considerably higher risk of progressing to metastatic disease by the time of diagnosis. And so indeed, the epidemiologic analysis and modeling analysis confirms, this is a couple of papers that have been looking at genetics, confirms that prostate cancer is a different creature in black men, and we should be treating it differently. So what should we be doing differently? Well, once we have, showing you here, once we have this information about what's going on below the surface, we can get very interesting and informative summaries of the burden of disease. And so what this is showing is by age, this is the cumulative risk of a prostate cancer that without screening would be diagnosed in the future within the lifetime of the patient, because we know that many prostate cancers are not diagnosed. They stay silent, particularly in older men, and the patient will die of something else. And so that's a real latent silent prostate cancer. And this is the cumulative incidence of the non-silent prostate cancers that will eventually become apparent. And for all races, this is the risk, and for African-American men, this is the risk. And so at age 55, for example, the risk for all races matches the risk for African-American men really around age 45. And when we look at the U.S. Preventive Services Task Force recent guidelines for prostate cancer screening saying that men age 55 should discuss screening with their doctors, it turns out that among black men, that risk is actually at age 45. So potentially, this really gives you a justification for some of the hand-waving that's done about maybe starting earlier. Now, there's also a question of what else we could do. Should we screen more frequently? And I have a few slides on that. In the interest of time, I'm not going to go into that, but I'll just show you, tell you that we're looking at all the different ways that we should be intervening potentially more intensively in African-American men. Well, I'm going to skip over those and come to my conclusions, and I have a couple of slides after my conclusions that I really passionate about and want to share with you. So in conclusion, racial disparities are significant and they're persistent, and we believe that more aggressive disease calls for a different approach, and the work that we're doing will provide concrete guidance to policy panels about what to do. The only thing that we need to be careful of is that the kind of natural reaction to a high-risk situation is to say, let's intervene more intensively, but we have to be careful because in prostate cancer, we always have to be balancing the harms of overdiagnosis with the benefit. I want to say that racial disparities are not the only kind of disparities to consider. There are big socioeconomic disparities. There are big disparities between rural and urban populations. There are big disparities by health status, for example, obesity status, by English as a second language. So there's very interesting disparities to look at, and this work overlaps with this general question about how to manage high-risk groups that Heather is going to talk about. Now, why are we find ourselves with a dearth of data when it comes to minority groups that may be of higher risk? And so as a statistician, I've always used other people's data, but I've become an activist in my old age, and I've become to realize that we have to create our own data, and it's now more possible than ever before. This is a slide from the Metastatic Prostate Cancer Project out of the Broad Institute, which is going via social media and advocacy groups. I highly encourage you all to look at this page. It's grown out of their initial metastatic breast cancer project, and they're very focused on genetics, and they interface with a large number of people via this social network collecting of a cohort. But I think that we need a black men's prostate cancer cohort, and we need to focus not only on genetics, we need to look at lifestyle, we need to look at decisions along the continuum of care, from screening to initial treatment to surveillance to secondary treatment for progressive disease. And so I've founded we have founded Fred Hutch Task Force on Disparities in Urologic Health. If you enter Fred Hutch Task Force on Disparities in Urologic Health, and our objective is going to be to try to create the data that we need for assessment of risk and management of prostate cancer in minorities and high-risk groups. Thank you.